sponsorships that they do for the Chamber, and we greatly appreciate AT&T's support of the Chamber, Alan. So I'm going to turn it over to you, and thank you for being here today. Thank you, Mitch. Good morning. How's everyone doing today? Good. Just a couple of words, I like to share sometimes a couple of new things that are going on with AT&T. First of all, you know, it is March Madness time, and I'm mad about March Madness because the UT men are not in it, okay? But that's a whole new, but at least Kentucky's not there either, right? So that's a good. The women are play tomorrow at 1:30, I think, 1:30 against Oral Roberts. So like usual, we'll watch the women go to New Orleans this year. I think this is Final Four in New Orleans. So if you don't have an app on your phone, if you want to keep up this afternoon with the games and all weekend, all the way through the Final Four on your device of choice, you can get the March Madness app. Something that's new this year is AT&T is sponsoring with Twitter short video clips, and so if you follow March Madness on Twitter, you can get video highlights in a 15-second interval, and the ad comes up either AT&T or Coke Zero. So we're both doing that. So it's kind of an interesting deal to keep up with the games, not like it used to be, you know, 30 years ago when you had to go and find a TV somewhere to keep up with all that. Second thing is good news about one of the rating companies, independent rating companies, RootMetrics, rated AT&T as one of the fastest 4G LTE carrier in the country after a study of 77 markets across the country. And we're very pleased that that happened. We're also the largest 4G network, not LTE, but 4G network covering the most people in the country. And that led to something interesting, or partly for that. At the end of February, we were awarded the contract with GM to do the connected car. You know, OnStar's been out there for a long time with GM. Verizon has been the carrier. We won the contract against Verizon this time for providing the OnStar services, but we're going to take it to a whole new level. We're offering infotainment to the car. You can stream, perhaps later, UVerse, if you're using one of our UVerse systems, UVerse to the back seat, not the front seat. To the back seat for your kids when you're going on vacation. It'll be a traveling Wi-Fi hotspot. You'll be able to download or stream Pandora music as you drive along without having to use your phone because it'll be integrated. And it will even do things like this. Say, for instance, down the road. For instance, if Mike Edwards is traveling to Nashville and he's about to run out of gas, you know, the little voice in the box will say, you know, something like, well, maybe, Mr. Edwards, you're getting low on fuel. Would you like to pull over at your favorite travel center, Pilot Flying J's, coming up just down the road at the Murfreesboro Road, Lebanon location? Yes, that would be good. And also, would you like for me to get a hot dog and a Coke for you to go to and have that ready for you? Yes, but make that 2 hot dogs. And so he pulls in, you know, he does the gas, and he pulls out his mobile wallet also with the new thing we're doing there, and just pays with the device that's on his phone with the near-field communications, does it, and moves on to Nashville. So a lot of new and interesting things coming with the GM connected car. You know, how many times have you taken your car in and you had to go to a computer software update? What if down the road, if you just updated it wirelessly like you do your phone updates today too, you don't even have to take it into the shop. So those are just a couple of things that are going on. We're doing a lot of work in healthcare and things like that too. But talking about being connected, we think events like this help keep us connected to our state officials and all of our public officials, and we think it's real important to have dialogue. We're real encouraged with the number of folks that are in the room today, and we have a couple of speakers. I'm not sure if Representative Johnson is here yet, no? So hopefully Gloria Johnson will be on her way soon to be with us, but we have Senator Becky Massey is here, and Susan Richardson Williams might have a one-on-one kind of conversation with Senator Massey here, so it's going to be good.
We have a plan.
You have a plan.
We have a plan.
Now, Susan will always have a plan, so I want to turn it over to Susan Williams and look forward to the program. Thank you.
Yes, sir. Thank you. Becky, you want to come on up, and I'll give you that, and we don't have to pass it around right now.
Well, no, we've got the plan.
Yeah, we're expecting Representative Massey. If she comes in, we'll
Johnson.
We'll excuse me. We'll get her wired if she comes in. The topic today is healthcare. I know there are a lot of healthcare folks in the room, and you probably, hopefully, have a lot of questions. It's certainly been one of the major topics. Besides the budget, I guess that may have been one of the most prominent issues before the General Assembly this year. And as you know, there's been discussion about the Medicaid exchange and expansion. We've got some bills down there now that would opt the local insurance agents in Tennessee out of Medicaid expansion if it goes through. There's all kinds of health issues pending before the General Assembly, so we thought it would be good to get Senator Massey and Representative Johnson here today. If she comes in, again, we'll fill in. If not, I've asked John Sheridan, who is probably in the General Assembly as much as the legislators are every day. John works for UT Med Center, and of course, all of those issues that we talked about are very important to the healthcare folks in our area. And we've had John's on our Government Relations Committee, and we've had he and Jerry Askew, another one who's down there a good bit, to kind of keep us up to date on what's happening in the General Assembly on health issues. So we're going to just start this morning, and please ask questions and ask questions.
Get John on up here.
Yeah, come on up, John.
John can answer as much as I can, so we're going to, he's down there and hanging out in my office all the time. You sit here, and if she comes in, you can pop out of it. She's probably on Nashville time, which I almost was. So.
Becky, why don't you introduce yourself? We all know who you are, but tell us what district you represent and what committees that you serve on in the Senate.
Okay. One, just thank you for having me here today, and I'm not a morning person either, and then I almost was on Nashville time, so we're lucky we're either one of them. But I represent the 6th Senate District, and it is the largest landmass in Knoxville. It encompasses both rural, suburban, and inner city. So we go from out in Halls, it cuts over to Corrington, and it comes all the way up to the Carter area, and then it comes in through East Knoxville, comes into a little bit of the center city around the O'Connor Center and Stermore Green and Austin East, and then it cuts across the river all the way to the Blount County line, and then West Knoxville, it picks up at Sequoia Hills, the West High area, Pond Gap, Bearden Elementary, and then it pretty much goes south of Kingston Pike with a few exceptions all the way out to the Loudoun County line. So I really, to go from Concord to Corrington, it's a distance, but it's a great district. In the Senate, I serve my primary committee. We're on 3 committees, but my primary one that I really had asked for, and I think a lot of my friends had advocated for, was the Health and General Welfare Committee, with my experience at Sir Thomas Center, serving adults with disabilities and understanding long-term care and things like that. I'm also on Transportation Committee, and you know, it's interesting, and I think some of you were there, but when somebody's road is messed up or there's a potential road problem, it draws out more people than anything else. I mean, you saw that evident out at South Doran where there was 400 people about the James White extender. And then I'm also on Government Operations. This is the one committee that technically could close down any department of state government. So they keep them accountable, and also looks at any kind of rules. If a department is putting into new rules in place, they have to come before us and explain the rules and the need for it. And if the citizens or concerned parties are opposed to those rules or want to comment on them, they are there voicing those opinions too. And then the Senate Calendar Committee is a little different than the House. There's 3 of us on the Calendar Committee, myself and the Minority Leader and the Majority Leader, and I am chair of that. A lot of it is on autopilot, but I have to present the calendar every day on the floor of the Senate. So.
Perfect. Thank you. John, you want to talk a little bit about what you do?
Where do you spend most of your time?
Right.
Yeah, the rent for a coat hook in Senator Massey's office is relatively inexpensive, so I'd recommend that. My regular responsibilities, I Vice President for Government Relations for the University of Tennessee Medical Center, which means I divide my time between Nashville and Washington, as Keith and some of the others would appreciate. There's a huge majority of our business in healthcare these days that's impacted by a government entity one way or the other. So we made a decision several years ago that that was going to be an important part of our success, and so about 8 years ago I took on those responsibilities. I do spend a great deal of time with the health committees in either the House or the Senate. I looked at my list yesterday as I was coming back from Nashville. I'm still tracking 41 bills that have some material impact on the medical center, and probably about half of those we hope would not get out of committee and not ever be voted on, and but the other half we hope they are voted on, and those that are voted on, there are probably some amendments one way or the other that would help us understand those a little bit better. So that's kind of my responsibility. I do have some interest in the Transportation Committee, and I apologize to those of you who are motorcycle riders, but there is a bill in the legislature right now to repeal the mandatory helmet law for motorcycle riders. Those of us at hospitals think it's a good idea for people to wear helmets. We understand personal freedom and personal choice, but some things are for the public good. So I have spent more time in the transportation committees this year than I had intended to, but health committee is where I spend most of my time.
Well, since you brought that up, Becky, why don't we talk about that, and if any of you have, let's kind of, again, make it a very interactive session. If you have questions about any of the questions we're asking and talking about, just feel free to ask them as we go.
Well, the helmet bill has wings this year somehow, and I don't agree with it, but somehow they have gotten a positive fiscal note on it between paying a $50 fee to have a sticker to ride the motorcycle helmetless, and the taxes on the new motorcycles that are sold and all this. I mean, Senator Overby and I sat down and met with Fiscal Review the other day, and I said, your medical costs are way too low. You know, here's this, here's this, here's this. So, you know, being in a field that I've got a couple of the folks that we serve that are brain injured, and knowing the effects of that, knowing the cost and everything, the costs are more than just even the base cost. You've got the long-term care cost, you've got the emergency personnel cost, you've got the family cost, and if somebody is brain injured and lives, I mean, even if they die, there's still those first costs that I don't think, you know, the MedVac costs, what, $17,000 at UT Hospital, you know, and things like that. But the families often end up going bankrupt. They end up having to go on unemployment, long-term care, disability, and things like that they're not figuring in. And so if it was just a personal freedom cost, I could come a little closer to swallowing it, but it's not just a personal freedom. If this passes, it's going to affect everybody in this room, and we're all going to be paying more. And at a time when we're looking at other significant costs in health care and things like that, we can't do it. But right now, it passed out of my committee. Unfortunately, we didn't get to fully vet it. There was some confusion there. And it's passed out of the House committee. It will be in the House Finance Subcommittee next week. It's not on the calendar yet for the Senate Finance Committee. I've been kind of working with them, some of them, to make sure it does get hopefully fully vetted there. And we've got a pretty good committee on that with several doctors and things, and I've charged all my folks like this to really be working that committee. And actually, one of the state reps last night was asking for comments on Facebook and had over 100 comments on it, and people were, you know, saying, well, it's just personal freedom, and some were saying against it. I ended up doing a thing this long on it. I had to kind of add the other costs involved that weren't there. So I feel pretty strongly about that too. So,
John.
In the count yesterday, knock on wood, the count yesterday in the House Budget Subcommittee was 6-6. So if it stays 6-6 times, it's going to die in that committee. So that doesn't always mean last week in the House Transportation Committee, it was 9-8 no, and one representative who said he was going to vote no and walked in the room and voted yes, and it passed out of the committee. So it's always unpredictable, but we're close to the Dragon here, and I've told folks one of our helicopters stays at a campground the first pretty weekend that the Dragon is open. It won't be this weekend because it's supposed to snow, but next weekend the weather's pretty. First spring weekend, everybody gets a motorcycle out, and we just leave one of our Lifestar helicopters at the campground on 129 because we know we're going to make 7 or 8 trips between Friday night and Sunday night. But anyway, that's one we wish we didn't have to deal with because there are a lot more important things that are going on.
Yeah, no kidding.
We're working together on that one.
Good. All right. Well, anybody has any opportunities to contact your legislators, let us know.
Look at the Finance Committee people.
Yeah.
Now, right now.
All right, let's get into the two biggies that have been down there this year on health care. A couple of decisions that are related to the Affordable Care Act, or Obamacare, as some of us call it. One was whether to operate our own state health care exchange, and our governor has made the decision to let the federal government do that. The other is whether to expand our Medicaid program. And that is, of course, something we're waiting to hear back from the governor on what his recommendation is on this. The chamber, through the Government Relations Committee and then the board, has taken a position on that, and we, through a lot of meetings and a lot of input, decided to support the expansion with the caveat that Tim Williams put forth, that we terminate the expansion and involvement with it if the federal support ever falls below 80%. It's supposed to be a 90% reimbursement. So I guess the question becomes, where are you? What are you hearing about this? Have you talked to the governor? Do you have any idea if he's leaning one way or the other? And then, John, I'd love for you to explain where the hospitals are on this issue as well. So, Becky.
One, just on the governor's decision on the exchange, we had a conference call like the day after the election back in November, and it was a conference call with all members of the General Assembly, but of course you were muted unless you did a little thing or whatever. But if you could imagine getting that many people that are talkers on there. But anyway, at that point, that was when the decision was supposed to be made, within just a matter of days. And with the information he had right then, I felt like he was actually leaning toward it at that point. But as when they got the extra time, as he looked into it more, it really wouldn't have been the state operating its own exchange. There were too many rules and regulations and answers they could not find, and I feel like that was really why he chose to do that. As far as what's going to happen, I'm not sure. I think every day probably he kind of goes a little bit different, depending upon the information he's gotten. So it's anybody's guess. I think he probably will vote for the exchange or ask for the exchange. What happens then, is going to be anybody's guess. I know there's been some of the folks like John that have been kind of counting votes on the waiver. I basically, have talked to a lot of folks, and at this point, I'm supporting basically the Florida plan, the 3-year exchange, and then revisit it at the end of 3 years for 2 main reasons. And sorry, John, the hospital's not my main reasons. It's there, but it's not the main. The main reason is, one of the things that I am most passionate about is our vulnerable populations. And, oftentimes those folks don't have a voice down in Nashville. They don't have lobbyists or very small lobbyists, things they can't come down and speak for themselves oftentimes. And I feel like if we can save some folks' lives in this 3-year period while it is 100% funded, yes, it is our money that Washington doesn't have, but they seem to want to spend it anyway. So if it's going to be spent and we can save some lives and help the health of folks, then that is a primary reason that I'm supporting it. Secondary, I do believe if we infuse that money into Tennessee over this period of time, it will help the economic impact of Tennessee, which will help businesses like a lot of you all that are sitting in here. And I think that's important too. I mean, the stronger we are economically in Tennessee, the more things we can do to help everybody, whether it's education, whether it's the hospitals, whether it's our vulnerable folks. So I think that's extremely important. The hospitals is in the equation. It's but it's those first two are really the ones that push me over the edge as far as that's concerned. The one caveat, and I don't know if this is practical or not, but I would like everyone who is able to be added to the TennCare rolls to sign a waiver saying, I understand this could only be for 3 years, because that's one of the things. I know Martha's sitting there going, that's, but just to acknowledge that, for right now it is for 3 years, and then we're going to look at it, and hopefully if the economic impact is there as much as I think it will be, it will take care of keeping it going once we start having to pick up the extra share. But the problem I have is when that additional cost comes, if the economic impact is not there, then we're going to have to look at taking that money from other things. We'll have to look at taking it from education, from K through 12, or from our higher ed areas. We'll have to take it from our roads, from our health care. And, I know we've got to, we help fund the Knox County Health Department and places like that. I don't want to see that money go down because of that expansion. So, but I think, that would be a discussion 3 years from now. And so that's why I'm kind of supporting the 3-year plan.
Expansion. For those of you that may not know how this works, this was the recommendation, there's an option to either expand Medicaid in the states or you choose not to take federal help. Federal government for the first 3 years would pay 100% if Tennessee chooses to expand Medicaid. And if we do that, that's our TennCare in Tennessee. And if you remember a few years back, Governor Bredesen had cost issues with TennCare, and so took a couple 100,000 people off the TennCare rolls. And so this, if we expand Medicaid in Tennessee, again, funded by the federal government, who is us, if we choose to expand Medicaid, 300,000 or so estimates could come back on the rolls. The first 3 years, the feds are committed to 100% funding. After that, they're committed, at this point in time, to 90% funding.
Why don't you talk about the disproportionate share?
Right.
The two issues on the exchange, most of the healthcare providers across the state understood and appreciated the governor's decision on the exchange, because what the exchange basically is kind of like people in certain categories based on your income levels would be able to go to something almost like eBay or Craigslist and shop for your health care online. And the insurance companies would provide products, and you'd be able to go out and pick, and you would either get a subsidy or a tax credit, and you'd be able to buy health insurance on the exchange. At the time that the decision had to be made, there really weren't enough rules from Washington to understand how it was going to work, and so we think the governor probably made the right decision on the exchange. Expansion is a totally different issue. As Becky said, those 250,000 people who would be in that expanded population are a very vulnerable population. There are a lot of them are the people who were disenrolled from TennCare a few years ago. They would come back on, they would have coverage. My sort of answer to legislators that I've talked to has been, these 200,000 people, it really doesn't matter whether they have a card in their pocket that says they're a part of this population or that population, they still get sick. They still come to our hospitals. They come to our emergency rooms, which is the most expensive place to get care. So they come to our hospitals, we take care of them, and we sometimes get paid and sometimes we don't. Our thought is that for the next 3 years, we would be happy to get 2 cents on the dollar for those patients that we take care of rather than no cents on the dollar. And we're comfortable with some backstops or some other things in whatever plan the governor decides to do to say, you know, if the federal government doesn't hold up its end of the bargain and doesn't fund it at a certain level, and Tennessee decides in 2 years or 3 years to get out of the program, we can support that, but at least give us the opportunity over the next 3 years with a little bit of reimbursement for those patients to be able to try to figure out a system to provide them with health care, because as I said, it really doesn't matter whether they have a TennCare card in their pocket or not. They still get sick and they still come to us, and we would like to be able to do some things. And Knoxville is a great advantage because there are a couple of programs here between the Interfaith Health Clinic and Project Access, CAPA, which is a coalition between the Academy of Medicine and the hospitals to take care of patients. Right now, we have the option, and there's some federal rules that say if anybody shows up in your emergency room, you have to treat them, but there's some waivers there that say we can triage a person, and if it's a sore throat, we can get them in to see a physician rather than admitting them to our emergency room. We had 82,000 visits to our emergency room last year, and that's a lot of folks and a lot of people coming through, and you add whatever portion of that 250,000 are in East Tennessee, that's a real overload on our system, and we would like to be able to, at least over the next 2 or 3 years, try to figure out a way to provide appropriate health care for those individuals in a setting other than a hospital emergency. We certainly understand and appreciate where people like Senator Massey are. There's some very thoughtful people in the legislature, in the House and Senate, who understand the financing and the impact that this could have on the state of Tennessee, even to the point of, some don't trust the federal government to uphold their end of the bargain, and that money's that charge and that expense is going to come back to the state, and how do we absorb that? The other that's kind of the unknown in this that doesn't get talked about a lot, but right now, only about 80% of the people who are eligible for TennCare in the state of Tennessee are enrolled in TennCare. So you've got about 20% of the population that, if there's an expanded population and all of a sudden it's, you can sign up, if 30% of that 20% enrolled, and they're not enrolled because either they didn't want to, they hadn't heard about it, didn't need it, and thought, well, if I get sick, I'll go to the hospital, I'll go to the doctor, and I'll sign up when I get sick. If that 30% of the eligible but not enrolled, they don't fall under the 100% reimbursement. They fall under the current formula, which is 30% by the state and 70% by the federal government. If that percentage of people, a small percentage of those eligible but not enrolled come on, that could be the cost of somewhere between $60 to $75 million a year to the state of Tennessee. And that's not included in a lot of these other discussions, but it's kind of an effect that if other people are expanded than those who are not enrolled but are eligible, if they enroll, that's an added expense. So that figures into the equation too. How do you cover that group of people at the current formula, not the 100%?
Yeah, I saw pulled off an interview yesterday. The Heritage Foundation had looked at the impact on expansion, Medicaid expansion in Tennessee, and it said $1.2 billion cost to Tennesseans between when the feds quit funding in 2022. So it's a big amount of money. Martha, do y'all have any additions you want to add to that?
Yeah, a couple of things that I think are real important.
Tell people who you are.
I'm Keith Goodwin with the Children's Hospital. You could argue, since a lot of this is being funded through Medicare, I don't have a big dog in this fight, except I do think of that as a whole cost of health care as a series of ripple effects. It will affect us eventually. But there's a real important point that I don't want this group to walk away thinking that this is new money that Medicare is going to have to find, or that Medicaid is going to have to find to fund this. The hospitals have already agreed to a series of cuts that started in 2010 that will continue through 2019 to fund this. So the state of Tennessee's adult hospitals, Medicare business, are taking reductions right now, and it's backloaded. So the biggest reduction reductions will occur in the 2018-2019 timeframe. In fact, the reductions are projected in 19 to be in the neighborhood of $1 billion of less money for Medicare services provided by adult hospitals. So that money that's legislatively done. That's happening right now.
That's called the disproportionate share, if you ever, part of it is.
Senator, part of it is reductions and then there's a disproportionate share, which is funds that come to hospitals who take care of a disproportionate share of indigent patients or patients who would otherwise be categorized as charity care. So the hospitals in the state of Tennessee, that's done. Those cuts are coming. That was done in a deal that the hospital systems around the country agreed to as part of this Obamacare. The corollary to that, and the trade-off was they'll accept what nationally was $155 billion in reductions over 10 years, but the Medicaid system will expand to take care of the charity care, what is now charity care. So you've got this counterbalance. Part is legislated. It's occurring right now. If you don't expand the Medicaid, the adult hospital systems in particular have the perfect negative storm. They're taking the reductions on one side, and the counterbalance that had been promised before the Supreme Court made their decision is now a state-by-state-by-state decision. So the counterbalance may not be there. That's a huge issue. And so I don't want anybody to walk out thinking that the federal government is trying to find new money to help fund this. It's already prepaid. And if it doesn't happen in Tennessee, and this is probably the grossest way to explain this, it'll go to California or to some other state who approves it. Now, I think the 3-year issue is absolutely true, and then there's a bigger issue about where the money's going to go in the federal government, how you're going to fix the federal government's budget. A lot of uncertainty with that. It makes all of us nervous. But just don't go away thinking this is a new pot of money. This money is coming out of the backsides of the hospitals right now to fund it if it's approved. And that's an important point, John, I want you to make.
Yeah, and the disproportionate share money is very important for the state of Tennessee. Statewide, the state gets about $90 million a year in disproportionate share money from the federal government. About half of that is divided amongst the 6 academic medical centers, UT here, our medical center, Erlanger in Chattanooga, Mountain States Hospital in Johnson City, Vanderbilt in the Med in Memphis. The Med gets the lion's share of that money, but it's a significant amount. And so the theory was if everybody's covered, then you won't need disproportionate share because everybody will have coverage and there's not an uninsured population. So as Keith said, if the disproportionate share money goes away and the reductions that we agreed to, and I think maybe if you took a poll of Tennessee hospitals, they may not have agreed to all those cuts, but the deal was made and the deal's the deal and it's in place. Those cuts in current reimbursements plus the reductions and gradual going away in the disproportionate share, that was supposed to be offset by the new people who were going to have coverage. If those new people don't have coverage and you're taking these cuts, it is a double whammy, and it's a very, very significant number for our medical center, and it is across the state. One of the groups that, in how the ripple works, it's very crucial to a lot of the rural hospitals. If you talk about Scott County Hospital, which is closed, but if it were open, the Scott counties, the Claiborne counties, even hospitals in Sweetwater and in some other areas like that, they had huge disproportionate share of uninsured patients. If without those disproportionate share monies, it really puts those hospitals in jeopardy. And those are a lot of times the largest employers in those communities. If those hospitals were to close, again, those people are still going to be sick, and they're going to go somewhere. They're going to come into Knoxville, to Chattanooga, to Johnson City. So it comes in and it just compounds the problems that we have. And in those communities, they're the largest, sometimes the largest employers. If those hospitals were to close, it would have a real negative effect. So it's a very, very crucial issue, and it's a very difficult issue for the governor to tackle and for the members of the General Assembly to make decisions.
Yeah, I think there are, 7 states that have not made a decision to this point. Anybody else want to say a few words about it?
I think Tim had.
Tim, you had a question, right?
John answered. My question was what percentage of TennCare was reimbursed? John answered it at 70. I thought I'd read 65.
It's 65-35, basically. There's a formula.
Kind of a 2 to 1.
Yeah, about 2 to 1.
Roughly.
So right now, the state has to put up about $35, and the federal government sends $65, and
Questions on that? John? Yeah. John, go ahead, Mary. Go ahead, Mary. All right.
Being about the dollars, but maybe, John, could you repeat just for us from a public policy, health policy standpoint, what the continuum of care looks like for a TennCare patient versus a currently patient? What will happen to those folks who get coverage? What does that look like for them overall?
Well, hopefully there's no difference. A patient's a patient. They come in the door with a condition that's diagnosed and treated exactly the same. The difference we all deal with it right now, we'll deal with it next year and the year after, is what happens to that patient when they leave. And we started the process of how do we get paid for what we did, and who makes the determination as to what the reimbursement is going to be for that patient. So as patients come in the door, patient's a patient, the patient's treated, and then we've always said we'll worry about getting paid later, but we worry a lot about it now because we may not be there later if those kinds of things continue. So it is an issue. There's some things that were a part of the Affordable Care Act where there were the MedPAC advisory committee that was going to determine, what are the appropriate levels of care for different illnesses. The one issue, and I'll get on my soapbox too much, but the big issue with the whole healthcare system is we get paid for the episode of care in the middle when somebody is sick. There are no incentives to providers to do preventive medicine or to take care of the chronic illness. One of the things that's in the plan right now, it says, and this is very simplified, but if you're a diabetes patient and you're in the hospital and you're treated and you go home, if you come back within 30 days, we're not going to get paid for the second visit because theoretically we didn't fix you the first time. Right. Well, if we have no control over what you did when you left the hospital, there's a good chance that you're not doing what you're supposed to do and eating what you're supposed to eat, you're going to be back in the hospital. So, there's no incentive to providers, doctors, hospitals, health departments, or others to manage chronic illness, and there's no incentive to do preventive things. And we only get paid when people are actually in our facility. And that's, if we can fix that part, and if that, over this 3 years, if we have an opportunity to do some things to look at how we deliver care and how we can spend money on the front end and spend money on the back end, we can reduce what we pay.
The one thing, though, that I would say that is a little bit different is that if we get some of these folks insured, instead of going to the emergency room, they'll go to their primary care doctor. They will maybe not wait till it's an emergency. Now, some people go to the emergency room don't have an emergency, but the others may go get that preventative stuff. They may be able to catch things sooner where it's not as costly, and that would be my hope in the insuring these folks, so that we will see less volumes in the emergency room with less significant illnesses, because it would be a little more preventative, maybe not the exercise that the diabetic needs to be doing, but a little more preventative.
Later.
Oh, I was wondering about the numbers. Just here in Knox County, the number of people that are uninsured, what roughly, how many people?
Martha.
That's a really tough number to track. Because how do you track those folks? I mean, it's easy to track people who have insurance, but tracking people who don't have insurance, where's that system? So I really don't have a good estimate. I don't know if you guys look
I think that's where the eligible but not enrolled is such a fluid number, because a lot of those people statewide, it's about 20% of those who are eligible for the TennCare program right now are not enrolled. And the question is, well, why are they not enrolled? Well, they didn't know about it. They didn't think they needed it. They didn't want to admit that they needed to be on the TennCare program, whatever the circumstance. And so it's there's some numbers out there. I'll have to try and find them for you later, but I don't remember them all.
You're right.
But that's 250,000 or so that's statewide.
Yeah. The expanded population that would be in that expanded Medicaid, expanded TennCare, the rough number is about 250,000. It's probably statewide, there are probably about another 150,000 that are in that 20% that are not enrolled.
Okay.
Pretty frightening, Martha.
Just to John's question about the continuum of care,
recently.
And so, you might want to think about it. You know, every day, those people, the patients and the providers deal with trying to find free care because there's no way to pay for that care. And so people don't get things because they can't afford it or can't find somebody to donate it. And they're not in Knoxville, where we have a really great network of doctors and providers who are willing to step up and take those patients. They're out in Granger County or Campbell County and just really struggling to find the care for those folks. So expanding Medicaid will make a difference for those folks, definitely.
And not to be any more negative about some of this, we already have been, but there are two other issues that are very critical, and we see it because of our mission as an academic medical center and training the physicians who are going to be providing all of us care in the next 20 years. We're seeing questions of people who are graduating from medical school and trying to decide what their residency is going to be. Am I going to go into a specialty, a cardiologist, a surgeon, pulmonologist, critical care medicine, whatever, internal medicine, general practice, versus something else, and knowing, you know, what are the reimbursements going to be? You know, what kind of lifestyle am I going to have? And that's an issue. And one of the things where we have an advantage, in the statistics will prove, if you have an academic medical center like UT Medical Center, where people come and do residencies, and we have 200 physicians who are doing their advanced training at our facility today. Those who are in family practice internal medicine tend to settle within 200 to 250 miles of where they do their residency. So it's very important for us to be able to continue to have those training programs, because people come and train here, surprisingly, like the rest of us in this room. East Tennessee is not a bad place to live. You come here and train, then you may stay here and open your practice, and that's good for the economy. When you buy a building, you buy equipment, you hire staff, and all those kinds of things. But if the incentives for care and what you're going to be able to do in your profession are not there, then you go somewhere else. And so we're seeing some shifts in what people are trying to decide, make their decisions about specialty versus primary care, and that's a real critical issue for us going forward. All of our residency slots for next year are full. We have a complete match with all of the things that we wanted to do. So we have a full complement for the next 3 years, but out in the future is people graduate from medical and dental school and try to decide where they're going to do their residencies. All of these issues about health care and what's going to be available and what kind of practice am I going to have become very important for our community.
Well, and another component to the waiver expansion is the availability of enough doctors. And I know, we're in a little bit better location being here in Knoxville, but I know that is a major concern, that with all these additional people and how long we're having to wait now when we go to a doctor, what do we get, 7 minutes, I think is the average you get to be with them. So that will be another stress to the system also.
Mike? Yeah, we've got, I think the only other question that I have that sort of involves this is there's a representative who has said he's found the Achilles heel, Representative Vance Dennis in the House, that he's found the Achilles heel for Obamacare, Affordable Care Act, that has a bill to prevent insurance agents in Tennessee from selling affordable Medicaid expansion. So the counter to that, I guess, would be, well, couldn't out-of-state insurance companies come in and then really hurt local insurance agents? That will have legs, or people think it's crazy?
And it has just surfaced this week, so I really haven't heard any conversations about it other than the article in the Sentinel. I haven't heard anybody down there because it's kind of started on the House side. So it will go before the Senate Health Committee, and we actually have a pretty reasonable committee when it comes to looking at issues of that nature. So oftentimes things start and they either, they may be off the wall or whatever, but then they either get amended to be more reasonable, or they get killed in one house or the other. Sometimes sometimes there's a bill out there, and you know, several of you know this, but both sides kind of play chicken to see which one, you know it's going to get killed, you probably want it to get killed, but you got to see which side's going to put the vote on so the other side doesn't have to. So that does happen at times too, but I don't really see that happening. That, you know, the General Assembly really is committed to being business friendly and to promoting, you know, lowering taxes and trying to do some things that are going to be more friendly for businesses to locate in Tennessee, or the ones that are here to operate efficiently. And that would not be a business-friendly piece of legislation.
Certainly not for insurance agencies. It did pass out of the subcommittee 6-2 in the House, so more to come. Thank you all for coming. Thanks, Senator Massey and John. Thank you for filling in.
I will belabor vote on time. Thanks a lot for making the effort to be here this morning. Very good job, Senator Massey. Thank you. Have a great weekend.